Welcome back to the program. Today we're talking to Dr. Chelvin Sng about MIGS, or minimally invasive glaucoma surgery. But in particular, we'll be speaking about early surgical intervention, or ESI. If you haven't heard that phrase before, it's time to listen in. Dr. Chelvin Sng, welcome to the program.
Hello, hi. Hi, Matt. Nice to meet you.
You too. Well, Dr. Sng, what are some of the primary treatment strategies currently available to glaucoma patients?
So the primary treatment strategies would be medications, predominantly in the form of eye drops, as well as laser procedures and surgery.
Well, can you describe some of the adherence issues that arise with topical drops? For example, why is compliance important and so low?
Yeah, you're right, absolutely, Matt. So in general, patient adherence with topical glaucoma eye drops is poor. And some studies have shown that even in developed countries like Singapore, up to 50% of patients do not use the eye drops as regularly as they should. And compliance is so important because when the patient misses the eye drops, the eye pressure increases. And this results in irreversible glaucoma progression in the long run. And the compliance is low because patients often forget to put their eye drops, or the eye drops are causing side effects such as redness, itchiness, and discomfort.
Could you also talk about some issues created by poor adherence? For example, disease progression?
Yes, poor adherence results in disease progression, and sometimes the patients do not admit to poor adherence in the clinic, so they use their eye drops just a few days before their appointment. Hence, the IOP is actually good in the clinic. And when we identify glaucoma progression on the test, there's a diagnostic conundrum whether the progression is due to poor adherence or whether we should lower the target IOP some more by adding more eye drops.
Now, is poor medication adherence a reason to consider early surgical intervention, or ESI?
Yes, certainly poor medication adherence is a good reason to consider early surgical intervention. If the patients are not using their eye drops, controlling the eye pressure with glaucoma surgery would prevent irreversible glaucoma progression.
What are some other reasons you would consider ESI?
So I would also consider early surgical intervention if the patient is unable to tolerate the eye drops because of side effects, if they have a poor technique for using the eye drops because of medical conditions such as rheumatoid arthritis or stroke, so the eye drops are not getting into the eyes properly, if they have a visually significant cataract and require cataract surgery, then I would also consider glaucoma surgery as a phacoplast procedure.
Now, what types of ESI do you currently perform, and which procedure do you perform most often?
I perform laser procedures such as selective laser trabeculoplasty and also mixed procedures such as the hydrous microstent, eye stands, Zen, and the PreserFlow microshunt. So I perform a lot of these mixed procedures very commonly.
What types of patients are best suited for MIGS and ESI?
So I find that patients who have 1 to 2 glaucoma medications and have mild to moderate glaucoma are most suitable for mixed and early surgical intervention.
And at which disease stage should ESI be considered?
So I would consider early surgical intervention for patients with mild to moderate glaucoma, and I would use a device or a surgery with a high safety profile for them.
Now, in Asia in particular, do you think the popularity of ESI will rise as the adherence rates continue to do poorly?
So if the prices of mixed devices would decrease, then certainly I think that the popularity of these devices would rise. And also as more surgeons get trained in the use of these devices, they would be more confident to offer these to their patients.
By the way, why would ESI be an effective and safe option for these patients?
So many well-designed studies, such as randomized control trials, have shown that trabecular bypass MIGS is a safe and effective option for mild to moderate glaucoma patients as a phacoplast procedure. And combined cataract surgery with trabecular bypass MIGS does not increase the risk of serious complications compared with cataract surgery alone, and is also more effective in lowering the IOP and the number of medications required. And in particular, The hydrous studies have shown that combining phaco with hydrous reduced the incidence of subsequent glaucoma surgery compared with phaco alone. And this is a great incentive for patients to have combined phaco with MIGS when they have a visually significant cataract, even if their glaucoma is medically controlled.
Are there any drawbacks to ESI that we should be aware of?
So the cost of these procedures is certainly a drawback, and hopefully they will be less expensive as the sales volume increases with the globalization of MIGS. And unlike the trabecular bypass procedures, the subconjunctival MIGS devices such as Zen and PreserFlow microshunt do have a risk of blood-related infections. Hence, I would also use these devices more in medically uncontrolled glaucoma and would try to avoid them if the patient has very mild glaucoma.
Is there anything else that you'd like to add, Dr. Sng?
So I'd like to emphasize that patient selection is very important for the success of MIGS. And a lot of the misconceptions about the efficacy of MIGS stems from the wrong patient selection, resulting in some even calling it minimally effective glaucoma surgery. And if trabecular bypass MIGS is performed in a medically uncontrolled patient on 4 medications and very advanced glaucoma, certainly the efficacy would be low. But they can have very good outcomes in the right patients, in the mild to moderate glaucoma patients on 1 to 2 medications.
Dr. Sng, thanks for your time today. Very informative interview.
Well, thank you very much, Matt. It's always a pleasure to speak with you.